medical mycology, systemic mycology. Mainly here dealing with systemic mycosis. Prior to that, we have to recall superficial cutaneous mycosis. Includes tinea nigra, pietra, tinea vesicola likewise, and dermatophytes, microsporum, trichophytum, and epidermophytum species. Subcutaneous or deep mycosis includes mycetoma, spirotrichosis, rhinosporidiosis, piohypomycosis, subcutaneous zygomycosis, but I accept mycetoma will be enough, and spirotrichosis. It's a dimorphic fungus. For systemic mycosis, it's mostly soil saprophytes like other fungi. Infections varies degree of severity, mild, moderate, severe, fatal, asymptomatic to fatal, like thermally dimorphic fungus. So that implies at a one temperature, for a room temperature and body temperature, they are different. Body temperature of the is like, but in room temperature, they are at mold or more complex form. Usually, there are organisms which for systemic mycosis are blastomyces species, paracoccidomyces species, coccidosis species, and histoplasma species. They cause blastomycosis, paracoccidomycosis, coccidomycosis, and histoplasmosis. We begin with blastomycosis, caused by blastomyces dermatitis. It's a telomorph in a perfect state. It's Agelomyces dermatitis, but what you know better know is blastomyces dermatitis. That's all. And paracoccidomycosis, which mainly caused by Paracoccidosis brasiliensis, and coccidomycosis caused by Coccidosis immitis, and histoplasmosis caused by Histoplasma capsulatum. Systemic mycosis. Further, you can appreciate what I said. Here they are. Yeast form likewise. Opportunistic fungi, Candida, there are pseudohyphae, hyphae formation, germ tube, like this is a comparison. Cryptococcus, it's a yeast. Aspergillus, it's a mold only, no yeast. So they are not dimorphic. Blastomycosis. Positive agent, blastomyces dermatitis. Chronic suppurative and granulomatous infection, especially of lung and skin. It was seen in North America, and that's why it terms North American blastomycosis. Mind you, these all four infections are endemic in North America, but time to time happens like case reports found in Africa, India, as well as in Sri Lanka. Pathogens is soil inhibitor. Saprophyte, inhalation of fungus spores, that's the main route of infection. Mainly it causes primary infection in lungs. It mimics tuberculosis or histoplasmosis. Maybe in some asymptomatic or leads to focal or diffuse consolidations, miliary lesions, or abscess formation. And later it can go for the systemic infection. So these infections mainly cause in immunocompromised people. So disseminated disease, lungs, blood. If develops disseminated disease, it's a highly fatal. Often cutaneous disease is found in skin or face or other parts. It's mild condition. Manifest as papules, around which secondary nodule develop and coalesce. They tend to join. Large elevated ulcerative lesions later on develop. Laboratory diagnosis. Depending on the pathology, we have to take some. If it is blood infection, blood. If it is lung, sputum. Skin, we can take biopsy. Lung biopsy, bronchoalveolar lavaggio, tracheal aspirates, bloody fluids. Usually in body needs seen in 37 degrees, 25 degrees or room temperature, filamentous with septate type. All the color cultures chlamydoscope can be seen. So what does imply? This implies. So if you take a sample, you have to put in both temperatures. No actinium here. Cycloheximide should not be added. If added, these microbes will kill them. imagine we take a skin biopsy in a normal cell line. We inoculate two plates, two separated dextrose plates, and one will keep at 37 degrees in incubator, mount in the 37 degrees, another one at 25 degrees. So we have to keep in two incubators. So these are the lesions. Subcutaneous one is the brown color. This is histopathology. About paracoccydomycosis, caused by Paracoccidioides brasiliensis. It's a terminally dimorphic. It was same like a chronic granulomatous lesion of the skin, lymph node or internal organs. It's confined to South America. Pathogenesis, mainly inhalation route, primary infection. Later, depending on the immune status, it can go for hematogenous spread via mucosa of nose, mouth, GI to lymphatics, leading to ulcerative granuloma of nasal and buccal mucosa. If it is from the mucosal route or nasal route, it was in the local infection, ulcerative granuloma, nasal and buccal mucosa. If it is inhalation, it was primary infection, it's the main way, and it's infecting lung. From there, it can seed into mucosa of the nose via hematogenous spread as well, or it can go for the mouth, GIT, and lymphatics. So then, in hematogenous spread from the lungs to mucosa of nose, ulcerative granuloma of nasal and buccal mucosa. Traumatic implantation also possible. Lab diagnosis, same as room temperature, hypal forms 37 degrees, but in knees. Here it's a peculiar feature. Once we grow them in SDA, large globose oval cells with multiple buds enrich in mother cells. And in a body knees form, there are multiple circular body in three-dimensional state image. So it appears marines or wheels of pilot's wheel appearance, just like ship wheel appearance. So these are the hematogenous spread leading to this ulcerative granulomas. This you can see again multiple body knees. If the slant is another one picture seen to microscope. Mold, seized, the room temperature, set the body temperature. Why it is in the body temperature? It is in yeast form. It's a highly pathogenic form and highly dynamic form. Whereas here in the room temperature environment, it's a mold form. They increase their surface area to absorb nutrients from environment or soil. That's why it's a more pathogenic form. Primary coccidioidomycosis, primary pulmonary infection, which cause inapparent or benign or severe or fatal. It's a dry region of southwestern US soil. Again, soil. Causative agent is Coccidioides immitis. It's mainly again inhalation of dust containing arthrospores, almost asymptomatic with lifelong immunity, more often asymptomatic. Self-limiting influenza like fever, desert rheumatism or valley fever terms. They develop self-limiting influenza like fever. Less than 1% develop chronic progressive disseminated disease or coccidioidal granuloma. This is the highly fatal. So even the healthy one can develop. Diagnosis again thermodimorphic fungi, room temperature and 37 degrees body temperature, it's yeast. So there are some delayed hypersensitivity testing because it's a chronic infection. So we can do some like for the tuberculosis, rapid plasma, like here we do oxidative testing. Arthrospore you can see. So here, so some skin granuloma. You can see box-like arthrospore here. So these are multiple state, different ways of cultures. Histoplasmosis. So intracellular infection of reticular endothelial system. Histoplasmosis, which cause Histoplasma capsulatum va capsulatum. In African variety, it's called Histoplasma capsulatum va dubosi. Earlier, they thought about it's the origin of leishmania, but it's not. Origin means those lesions they thought due to this leishmania, don't know. But later they identify as it is histoplasma. It's a fungus. Worldwide, but common in USA. Source, soil, rotting trees, and bird feces. Classical disease, asymptomatic, and heals spontaneously. So they cause biliary pulmonary lesion resembling TB, mimic tuberculosis. Disseminated disease occur in few, specifically immunocompromised people. Diagnosis, thermally dimorphic fungi, white polymyxil growth at 37, tuberculate spores at 25 degrees. Also, there's another one, histoplasma antigen testing. So you can see it's not multiple, but in like bit different. But you can see these arthrospores, you can appreciate. Treatment, usually oral itraconazole is given for paracoccydomycosis. Fluconazole orally for coccidial meningitis, it's go for intravenous. Amphotericin B is advised for invasive histoplasmosis. Oral fluconazole, itraconazole for less severe infections. That's the difference. So this is the other novel diagnostic techniques also there, but culture microscopy is the foremost, and PCR tests are not much like bacteriology and virology. Thank you.